think I'm on. I'm on. Okay. Here we go. So I thought I'd just come on and just give my thoughts. Talk at myself, to myself. So, it's really interesting working in the Cath Lab. So, uh, so my experience with the Cath Lab versus um, the floor. So I've done a lot of CNA work. I worked on as a CNA on the floor. A lot of rounding in vitals and walking patients, and taking them to the bathroom and changing Foley's and passing out trays. Done a lot of CNA work. And I've done a little bit of nursing floor work. Not a lot, but a little bit. And, my little experience I have as a CNA, as a nurse on the floor, comparing to the Cath Lab, I don't know. I think it'd be good. I think it's really interesting. The what I'm coming to, the revelation I'm having about, the differences. So I'm just going to talk about my experience. This is what I am observing, my thoughts and feelings, and we'll just leave it at that. So PCU stands for Progressive Care Unit. There's lots of other names for it. Step down, the step down unit, same thing. What's the other one? There's like DOU, Direct Observation Unit, same thing. There's another one like, there's like another one, sort of like an MCU or something. Anyways, there's the PCU is like technically under the like Critical Care Nurses Association. It's officially a critical care area, but you are limited in the amount of critical careness you can have. So PCU is like the middle between ICU up here, like critical, and med surge, like not so critical. So it's like boop, boop, boop. It's like med surge. Oh, they got a little sick. PCU. Oh, they got a little more sick. ICU. Oh, they're really sick. So, my experience between the two, Cath Lab is so different than the floor. On the floor, like on the PCU, you need orders for everything. And there's no doctor like at your beck and call. So the Cath Lab is more similar to the ER in that way, where you have a doctor, but it's even more convenient because, in the ER you have a doctor, but he's got the whole unit to run. So it's not just your patient. You have to still wait for him to get an order, or talk to him, But in the Cath Lab, the doctor, you are helping the doctor directly. So there's no, it's seamless. The order is seamless. When I say, hey, doc, I want to give this, right? Or, hey, doc, do you think we should start Levo, which is a vasopressor, right? I say, doc, you think we should start Levo? And he says, yeah, start some Levo. And I go and get some Levo. Whereas on the floor, PCU, one, you can't give Levo. And two, if you need an order, there's a process. You have to find the doctor's phone number. You don't get to just call the doctor. You have to page the doctor and wait for him to call you back. Then, when you call, he calls you back. You have to get to a phone and give your SBAR report to explain your rationale for why you need your drug, and then proceed to suggest what you want, and then wait for him to either say, yes, I'll give you what you want, or no, I'm going to give you something else, right? You have this long conversation with him about what you're going to get. And then, depending on the scenario, he may give you a verbal order, and you go put your order in. Or he may put in the order, and you wait for it to pop up to acknowledge it. And if it's a medication order, you may have to wait for pharmacy to verify that that order is appropriate for the patient before you get access to that medication, right? That can take anywhere from 30 minutes to an hour before pharmacy has acknowledged and verified the drug. And then if it's not in the Pyxis, which is the drug cart in the nurse's, station, then you have to wait for them to either tube you up the medication or stock the drug or what have you, bring it to the bedside. So you're sitting around, you may need something, and you're sitting around for 2, 3, 4 hours waiting for something. In the Cath Lab, you say, I'm going to give this drug. He says, okay, and then you go give the drug. Right? So, and not only that, but, for us, we don't really have a Pyxis, so I just go over to my med cart, crack the med cart, and strip it out and start running it. And it's different because, on the floor, you're going to have these very specific parameters. The doctor's going to say, give, Levo IV at between, 5 and 20, I'm just making this up, 5 and 20 mics per minute for a systolic blood pressure less than 90 or mean arterial pressure less than 65. And you'll have these very specific parameters and the amounts that you can run it. But down in the lab, I am not even going to ask him what he wants me to start it at. I'm probably just going to start it where I think it's a good start. So I'm going to say, hey doc, you think you need some Levo? He's going to say, yeah. I'm going to get the Levo and strip it out, and I'm just going to put him on it, on whatever I think. And there's no question. He's not even going to ask me, hey, until we're moving on. Once we have the pressure back, okay, hey, what's the Levo? Oh, it's at 15. Okay. And if I start moving it around, he's not going to question my movements on the Levo, right? So there's more autonomy. There's more freedom in the lab. A lot more freedom in your decision making. So that's one big difference. It's like getting an order from a doctor, right? Oh, and it's just so different, on the floor. So that's just one little thing. I could probably end up doing this. Let's see how long I can go and all the differences. I'm not going to be able to do all the differences. This is all off the cuff in my own brain. I don't make notes for my videos, okay? I go on tangents. I don't, I don't know. This is like stream of consciousness vlogs. Stream of consciousness vlogs. I just kind of go. I don't care. Whatever. So that's one difference. Talking about the orders, how the orders work. Another big difference is the patient ratio, right? So patient ratio meaning on a PCU unit, probably going to have 3 or 4 patients, maybe 5. 3, 4, 5 patients to one just to you by yourself. In the Cath Lab, it's 1 patient to a team of 4 or 5 of you. So in our Cath Lab, I'm a lucky duck because we have a 4-man call team or 4-man teams. And so some labs have 3-man teams. I really like 4-man teams, but there are 3-man teams as well. So you have the doctor doing the procedure. You have the scrub tech. You have the circulator. You have a backup circulator. and you have a monitor or like someone recording. So that's 5 people to one patient. Whereas on the floor, you may be one nurse to 5 patients. So, you know, and so that's, you know, you got 5 call lights. You got 5 family members, or four call. Let's say 4 call lights, 4 family members, 4 GI tracks. You know, your IVs. Oh my gosh, you might have 2 IVs per patient, so up to like 8 or 9 IVs, 10 IVs that you have to worry about. You know, 4 doctors. I mean, everything is multiplied. You know what I mean? So, not only that, but on PCU, you don't get patients on ventilators. So intubated with a tube down their throat, and they're sedated, they're sleeping, you know, they're awake. The most invasive airway they're going to have is like a BiPAP. And generally, if they're on BiPAP all the time, you know, it's not good. It's not a good look for a PCU patient to be on BiPAP all the time. So everyone's awake. In Cath Lab, we generally give moderate sedation or anesthesia to make the patient sleepy and not moving while we're working on them. So everyone's sleeping. No call lights. No GI tracks, really. Never had a patient poop in the Cath Lab. Knock on wood. So that's another big difference. You know, you have a lot less patient load because you're focusing on one specific thing. Oh, this just hit me. Another big difference. The floor PCU, there's not a whole lot of flow to the PCU. It's not a flow state unit. There's no flow. You know, you get on shift and you're sprinting from clock in to get report, right? You're sprinting to get as much information about these patients as possible within 30 minutes and then check up on them, make sure they're safe. And then it's a sprint till, for us, like 9 o'clock or something like that, to get assessments done, right? To get whole head to toes and IVs and pumps and all the assessments done and meds passed. And you literally just have to be ready for anything. Patients could be pooping at this time. Patients could be having family members in the room. Patients could need new IVs. Like literally there's an endless amount of possible bad things that could be happening. At the start of shift, from the start, you know, the question of am I going to get breakfast is up in the air every shift. You just don't know. You just don't know. You don't know what time, and you don't know, you know, how bad things will get. Things can get really bad and out of control. You can get on shift and you have a nightmare train wreck of a situation. And you're like, you know, patients falling out of bed when you get to work. Or, you know, someone's yelling or screaming in the hallway, demanding pain meds. I mean, literally, just never-ending list of unfortunate things that could be happening when you get on shift. So there's no flow. You know, the only flow is you're going to have to get assessments done by a time. You're going to have to give medications at certain times. And even that, you know, is relative because you're only one person, and if something bad happens, something has to get pushed back. There's only one of you. You can't be in 2 places at once, and you can't leave an unsafe situation if there's no one to replace you as the nurse, right? So if a patient's getting really sick and they need to be transferred to the ICU, and you see them deteriorating in front of your eyes, you call a rapid response. You're not gonna just leave that patient, right? You may be able to get a charge nurse in, but honestly, you're gonna ask the charge nurse to go check on your other patients, so you're probably gonna stay with that patient because you know them better, right? So, and they're not going to do your charting. They're just going to make sure they're safe until you're free so that you can go do your charting on those other patients, right? So you're not getting out of it, out of the work. You're just putting a safety net between your inability to leave the current room you're in and the safety of the other patients, right? You're having someone else check on them for you. Just keep them safe until I can get over there and do my job for them. Does that make sense? So that's very different than the Cath Lab. The Cath Lab is a flow state procedure. There is an ebb and a flow to the Cath Lab. It ebbs and it flows. There's timing and synchrony, and things happen and then we have a lull. Things happen and then there's a lull, or something happens and then it's there's this ebb and flow to the Cath Lab. So like we have a case and the flow is, hey, there's word that we have a case. The case may be here, right? There might be a case. That's where it starts, right? It starts with the thought or the idea of, hey, there might be a case. And then, you have a team of 4 people. So word gets out, all 4 people know we have a case. And then the decision gets made as to who is going to do what in the case. You're going to do this. You can do this. Or I'll do this. Or, hey, what's best for the situation? Who's going to do what in the case? And so this is the start of a case, right? The decision that there's a case. The doctor has seen the patient. We have confirmation and a room number, right? And then once that's established, we start to investigate. What are we going to get ourselves into? We start to get a flavor for the patient. What procedure are we doing? How sick is this person? What kind of, sedative are they going to need? What is the plan if, we have to do X, Y, and Z? Creating our backup plans, creating our stop losses, getting the case together, right? We're going to open up the sterile tray and prep the room. So this is like the start of it. Okay, now we've prepped the room. Somebody has decided, all the roles are established. And now someone or 2 of the 4 will go get the patient and 2 will stay here to keep the room ready. So like this is the flow, right? It's not like you get here and it's just all out chaos. Like that's how it is when you get on the PCU on the floor. It's all out chaos. Like you get there, you're like, okay, what patients are mine? What is going on with them? What is the plan for them? Where are they currently at? Where were they and where are they going? What do I need to know about all of the little intricacies of this specific one? Times 4. Now times that by 4. And in the Cath Lab, it's not like that. And then once the case starts, there's this flow to it. We're going to get access. Someone needs to get access. We're going to maybe anticoagulate. We need to confirm that they're anticoagulated before we start intervening. We have the start of the case. We're going to, maybe let's say we're doing a left heart cath. We're going to get up with the catheter. We're going to shoot the right. Then we're going to shoot the left. Then we're going to get an LV gram. We're talking about the coronary arteries. And then we'll decide, now there's a lull. What are we going to do? Are we going to use some invasive, diagnostics? Are we going to go stent or balloon something? Are we going to close up and call it a day and send them back home? Or send them back to the floor, right? So, there's this, you can only do one case at a time. The doctor can only do one case at a time. We can only focus on one patient at a time. Our sole focus is the safety and protection of that patient's health and maintaining their liveliness throughout the case and after the case, right? So there's no rush. Like if they're a STEMI or they're dying or they're super sick or cardiogenic shock, we're going to be rushing, right? We're going to be going quickly. We're going to be doing things preemptively. We're going to be starting doing things, that are interventions, life-saving interventions. But it's still going to be a flow, right? We're monitoring them. We're putting them on the Zoll. We're making sure, we're doing CPR and rechecking our pulse, right? Running a code has a flow to it. You have every 2 minutes or every 5 minutes or every few minutes, we're checking stuff. We're doing interventions. We're pushing drugs. So even in codes are very flowy oftentimes because you have to get your bases, cover your bases, and do, you can't just, it's not just chaos, right? So if it is chaos, then you're doing it wrong. But the floor is just friggin' chaos. It's just chaos. I mean, this is nothing I want to second time. So day shift. I'm talking about day shift specifically. I have not worked PCU night shift, and night shift may be a little different because patients are sleeping. You're not giving meds throughout the whole day, whole shift. You're not feeding them the entire time. You don't have like physical therapy and occupational therapy and case management and speech therapy and dietary and all these ancillary staff coming in and waking them up and moving them around and stuff, right? So night shift is different than day shift, but I'm talking about day shift PCU. There's no flow to the PCU. It's just you adapt, right? You react to what comes toward you. Something's going to hit you, right? They're going to come to you. You're just going to respond to whatever's coming to you and do your best to prioritize, right? 4 things slam at you. That's nursing. You get all these tasks, and your goal is to prioritize. Okay, what needs to be done first? That's my heater. I just kicked my heater. What needs to be done first, right? This is the clinical judgment, critical thinking, reasoning. I have 5 things need to do. They're all important. Which one needs to be done first, and what needs to be done second, and why, and how can I do them in the most efficient way possible? And so that's PCU, right? Not in the Cath Lab. So not only that, in a procedural area, right? Patient comes, and the patient goes. The patient comes, and the patient goes. The patient comes, and the patient goes, right? So that's not how it is in PCU. In PCU, you come in, and the patients are here. And the patients are staying until they leave. And then once they leave, you get another one. And then you may get another one. And then one may leave, and you might get another one. You're going to be maxed out all the time. The goal is to utilize you as a product, by management. You have a certain output that you can make productivity-wise. They want to keep you maxed out at your productivity at all times so that they are staying profitable. They're not, overstaffed for the amount of patients they have. So you're always going to have patients coming and patients going and full. You're always going to be full. In the Cath Lab, that's not true because you can only take care of one patient at a time. And the procedure requires them to come to you and leave you, right? There's no, I got this one, I'm getting another one, and I got another one, and I got another one. We can get add-ons, like, hey, we have this case and this case, and then after that we have this, this, and this. But they're not all coming at once. We can only do one at a time, right? So that's another thing. What's another thing? What's more stuff? Oh, here's another one. You don't work with CNAs in the Cath Lab, or whatever you want to call them, the nursing assistants. You don't have nursing assistants in the Cath Lab. There's no one under you. There's no delegation. Oh, there's delegation. There's no, what's the word? No, delegation. There's no delegation, right? Delegation is when, like, me as the nurse, primary nurse, delegates a task to someone who has a lower scope of practice to do something. Like, hey, I asked the CNA, hey, CNA, can you go get vitals in room 20, whatever, right? Oh, thanks. Go and get the vitals, thank you, please. And then they will come back to you and report back, hey, this was their vitals. You say, oh, thank you. Room 12 needs to use the restroom. Can you go help them with that, right? That's delegation. There is none of that in the Cath Lab. Everybody's on an even playing field, right? You have radiology techs and you have nurses, and they both have the same scope of practice in the Cath Lab, at least where I'm at. There's no telling someone to do something, for you below your, below the scope of practice, right? There, everyone's on the same playing field. So you have there's more collaboration, and there's more closed loop communication, asking for help. You're asking for help in your current state, right? Or asking them to do something to help you. But it's not you're not working with someone who you have to watch, right? So I have to make sure. So for instance, if I'm on the floor, if I'm on PCU, and I tell the CNA, hey, can you go check a blood pressure in room 10? They come back and they're like, hey, the blood pressure is really, really low, too low, so low. And I have to be like, oh, okay. And then I have to go over and see the patient and recheck the blood pressure. I can't just trust that they took it right. They might not have. There's a chance that they didn't take it right. They don't know as much as the nurse does. They don't know a lot of times how to properly take a blood pressure, honestly. The little blood pressure cuff's got a little arrow a lot of times that says artery. Put the artery. So you have a basilic artery or a brachial artery, right? You have to make sure the bladder of the cuff is against the brachial artery, right? And they are at a phlebostatic axis, right? So if you have the blood pressure high, or if you have the cuff wrong, or you have the patient talking or moving, or all kinds of little things can cause a false reading. And the CNA oftentimes does not use critical thinking, and they do not recheck the blood pressure or readjust the cuff or ask the patient, hang on, please stop talking, let's just take this really quick, and so because that can disrupt it. They just take the blood pressure and whatever it is, they just write it down, they walk over to you, and they don't care. That's it. So, and boom, and then they're gone. So you have to kind of chase your tail a little bit in the PCU, because you have to trust but verify all the information that's given to you by your assistant, right? The nursing assistant. Don't just trust what they say. You can't. You can take it in as a possibility, this may be a possibility. They're reporting to you, thank goodness, that they're telling you they think something. Awesome. Now let me go verify that is actually true, because it might not be. So that's another thing on the PCU that you don't have to deal with in the Cath Lab. You don't have any delegation. You don't have any CNAs. You don't have someone who's not licensed like you, really. That's another thing that I don't miss. What's some more stuff? The breaks. Cath Lab gets their breaks. And they get a lot of in-service education by companies of the products that they use, and they get fed food. They get catered food a lot, because the reps coming in, they're going to feed everybody and then talk about their product. Because when I'm in the lab and the doctor says I need a balloon, he's not telling me he wants a specific company's balloon. Generally, he'll take any balloon, any balloon. But when the rep is there, whoever company rep it is, we're probably going to use their balloon. We're going to use their balloon, right? So the reps have incentive oftentimes to come in, because we're going to use their product while they're there, right? While they're there, we're going to use their product. And when they're gone, they hope that we continue to use their product because we like it. And so there's incentive for the company to come in and make really good relationships with the Cath Lab staff because we pull their product off the shelf and we put it on the table. So they have incentive to feed us or take care of us, I guess. I don't know. Different than the floor. I've never seen a rep on the floor. Never once, not once ever, seen a representative from a company like Abbott or Boston Scientific or, Cordis or any of these companies, right? Medtronic. Never seen any of these companies' reps on the floor ever. And I see them all the time in the lab. All the time. They're always coming through. Because we are using a lot of their products. And they want to make sure that we are competent in how we're using them. That if it's not working, they want to fix it. They want to be, they're an integral part to the lab. So we get a lot of reps coming through. Different than the PCU. Those are some other stuff. What else? There's a lot. There's definitely a lot to this. Let's see where I'm at. I'm at 30 minutes. At 30 minutes. I know there's more. Charting. Oh, Lord have mercy. Oh, gosh. The charting in the Cath Lab, I don't do charting. I'll just say it. I don't do charting. There's no charting for me yet. Once I train to monitor, I'm not trained to monitor, which is like the charting job, which they do all of the hemodynamics, they do all of the bills, and they do all of the exchanges, and they do a record of the case, right? All the drugs, they keep a record of everything for what's happening. So right now I can circulate, I can back circulate, and I'm just training to do the scrub roll, and I'm not trained into the monitoring role. So I don't scrub. I don't scrub. I scrub. I don't monitor yet. So I don't really chart. The only thing I chart is my drugs, and it's just on a little piece of paper, just the name, the drug, name of the patient, and the doctor who agreed to me giving the drug. That's it. And I give that much. That's my only charting. It's my only charting. So on the floor, there's a lot of charting. I would say 60%, probably upwards more than 60% of your day is spent charting. You chart in the room, you chart in the nurse's station, you chart in the hallways, you chart everywhere, all the time. Pretty much every time you go in the room, you're going to chart something. Almost every time. If you go in the room and you empty the urinal, you're going to chart the INO. If you go in the room and you take their tray, you're going to chart how much they ate. If you go in the room to take vitals, you're going to chart their vitals. If you go in the room to give them medication, you're going to chart their medication. If you go in there to do a head-to-toe assessment, you're going to chart that you did a head-to-toe assessment. If you're going to go in there and you talk to them and they mention something about not wanting to go out, if they want to go out and smoke a cigarette, you have to probably chart that. You probably have to chart that they tried to get up and go have a cigarette. Probably on some level. You have to chart. Patient is, refusing or is not, patient's refusing, or what would you say? Patient denies need for smoking, nicotine patches. I don't know. If you get a call from the lab with a critical value, you need to call the doctor and chart it. You just chart everything. There's always charting constantly. And I'm not a fan. I'm not a big fan. Not a fan. Oh, not a fan. So that's a big difference. All I do is do. I just do stuff. I just like doing stuff. Not charting that I did stuff. Just do it. Just do it. So I really like that. I love it. What are some other differences? There are differences. I don't know. Those are some good ones. Oh, so at least in this lab, we don't have a MAR. We don't have a list of medications that I can give. I can literally give anything the doctor is willing to let me give, I can give. So there's no like, I need to call pharmacy and verify this. There's no, I need to call the doctor and see if I want to give this. There's no MAR that I have to pull from. There's just, it's just hang it. Just boom, hang it. So the only thing that you really need to chart is like blood. Like if you're giving blood and you have to verify the armband and blood number, right? The blood bank number, and But other than that, and even that, if it's a emergency blood where you're giving it O neg, uncross matched, not type and crossed, you're just gonna. It's all just, you just write on there time you gave it and how much went in and the patient's name on a piece of paper, and that's it. So even that, there's not a whole lot of charting. Yeah, so like on the floor, you're gonna like scan every med. You scan an armband, you scan a med, you look at the MAR, you do your triple check, you make sure it's the correct thing. You press click, you write a little note about something patient took with orange juice. I don't know. Blood pressure was do. You write the blood pressure in, and you save. And you make sure it's within the right time frame. None of that happens. So it's funny because it's like in nursing school, you train, you learn to give your medications, you triple check, you check it against the MAR, then you check it against the computer, then you check it against, one more time before you give it. And then you give the medicine, right? You triple check your medications every time. You check your rights, you check your patient, you do all these checks for these drugs, right? Over and 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 over. You do it for every drug, and you might have 20 medications you're going to give. You can do it all 20 for all 20. You triple check all 20. Well, in the Cath Lab, I don't have a MAR. I don't have a computer, and I don't have a scanner. I don't have anything. I have my hand. I can pick my drug up and look at it, and that's all. That's my check. I have to look at the medication, draw it up, and give it. So that's different. That's different than all of nursing school. That's different than all of floor nursing. That's different than nursing. That's just different than floor nursing. So that's a major difference. Another difference is like the scope of practice. In the Cath Lab, we use the ultrasound probe, and if the doc feels comfortable, he'll let you get access. So they teach us to use the ultrasound, and they teach us how to put a sheath in, and you're like injecting stuff into people's coronary arteries. You're injecting contrast in coronary arteries, and you're doing all kinds of crazy stuff that you would never do in on the floor. It's just, that's a big difference. Your scope of practice is wide open. A lot. You can do a lot in the Cath Lab. The autonomy is massive. So, and the knowledge base. I mean, understanding like internal diameters of sheaths, versus external diameters, wire gauges, wire, hydrophilic versus like hydrophobic wires, or like nitinol coated wires and like different access kits and different catheters. I mean, how many different freaking catheters are there? I wonder if I could start naming. Let's see how many catheters I can name. I don't know. This is not the shit for that, or the video for that, I guess. There's a lot. There's a lot of catheters. So many. So like knowing all of those things, and then grabbing the right one, and knowing when one is appropriate versus another. All this stuff. There's and that's part of I think the flow of the lab is like understanding what, all the products you have to know, all these different terms and techniques. On the floor, you don't need to know any of that. What else? I think that's good. What else on the floor? Discharges. You have to do discharges and admits, med reconciliations, obtaining histories, doing like psych assessments, checking their, code status, all the follow-up, planning and follow-up education, discharge education. There's just so much, so much talking, a lot of talking with your patient on the floor, times 4. And in the lab, there's a lot less talking. Your pre-op assessment, there's a little bit of talking. Post-op instructions, a little bit of talking. But for the most part, the patient is quiet the whole time. You're not talking to them. You're focusing on the case. You're communicating with your team and your doctor. That's who you're talking to. You're not talking to the patient or the family. You're not talking to anyone but your team. So, kind of interesting. A lot of differences. All right. That's all I got.